Good morning and welcome, everybody. The IATT is really excited to launch today the Option B Plus Monitoring and Evaluation Framework for antiretroviral treatment for pregnant and breastfeeding women living with HIV and their infants. The development of this framework has been a joint effort from CDC, WHO, and UNICEF, supported by the IATT MNE Working Group. I think we all agree that there has been rapid adoption and scale-up of B+ in countries with generalized epidemics, and this framework is an important resource for countries to review, adapt, and update current monitoring systems and continuously evaluate programs in order to maximize the potential impact of lifelong treatment programs to improve health outcomes and prevent HIV infections for women, their children, and their families. We have an exciting agenda today, beginning with an overview of the framework and followed by 2 practical implementation examples from Kenya and Uganda. We will then have a Q&A session and close with a summary for the next steps. I now hand over to Jessica to introduce the presenters and presentations.
Great. Thank you, Nande. As Nande mentioned, our first presenter will provide a global overview of the MNE framework and highlight key points from the document. Our first presenter is James Houston, who is a medical officer at CDC Atlanta for the Center of Global Health with the Division of Global Health at the Maternal and Child Health Branch. He has many years of experience conducting research in PMTCT as well as specializing in monitoring and evaluation. Without any further ado, I'll hand it over to James Houston to deliver our first presentation.
Thank you, Jessica, for the kind introduction. First, can I just ask, Jessica, can you hear me?
Yes, I can hear you very clearly. Great.
And I just click on Take Over Presentation. Is that correct?
Yes.
Okay. Okay. So it seems to be working. Great. Good morning, everyone. So the B+ MNE framework is designed as a tool for MNE officers, PMTCPs, and HIV care and treatment program managers and other stakeholders in countries with generalized HIV epidemics to use when monitoring and evaluating B+ programs. This is a document, as Jessica and Nande said, that was published last month by the IATT in a joint effort between CDC, UNICEF, and WHO, and it can be accessed to the link that's on the PowerPoint, as well as I think Jessica shared it within the chat. So I'm going to speak for a few minutes to highlight the structure and the main recommendations from the document, but I'm not going to be able to go through many of the details, and so I really encourage people to actually go through the document itself. It's only about 30 or so pages, but has a lot of details. And then representatives, as we've heard from Kenya and Uganda, will share some practical, like real-world experiences working on, have the opportunity to highlight some of the successes and challenges they've had implementing B+ for pregnant and breastfeeding women. So I want to first acknowledge that events have moved very rapidly over the last 2 years. Country programs have moved quickly to adapt the B+ recommendation within the 2013 guidelines, and in the process have committed to some level of integration of ART services into MCH settings. Initiating and maintaining women on ART within the MCH platform is a new service delivery model that has implications for how program data are collected, reported, and used. So there are 4 recommendations from the B+ MNE framework that I just want to highlight in my short time today. The first is the need to move beyond coverage of HIV testing and ARVs for PMTCT to measure retention. So this includes both ART retention at 6 and 12 months for women who are pregnant and breastfeeding when they initiate ART, as well as for the final outcomes for HIV-exposed infants at 18 months of age and/or 6 weeks after the end of breastfeeding. The second issue is the need to integrate ART and PMTCT MNE systems. The third is the need for enhanced monitoring during implementation of B+. So because B+ is a new service delivery model, real-time review of program data from a subset of sites can be used to rapidly respond to quality concerns as they occur, and this approach is important to consider for indicators that may have many programs have found challenging to collect routinely from all sites in the past. The final recommendation to highlight is to conduct process and systems evaluations in the early phases of rollout, to validate the data collected for monitoring, to collect additional qualitative information, including client perspectives on B+, and to identify gaps in the M&E tools and systems that would require modification. So I'm now going to explore each of these 4 issues in a little bit more detail. Starting with retention. Integration of ART into MCH requires measurement of retention for mothers on ART to ensure quality is the same as the rest of the ART program. Integration of ART into MCH is an opportunity to improve retention for exposed infants until the end of the breastfeeding period when the HIV status can be determined. And measurement of retention for mothers and infants requires adapting current M&E systems to allow for cohort monitoring. For PMTCT programs, there are actually 3 different cohorts of interest. There's the ART cohorts of patients initiating treatment. There are ANC cohorts of pregnant women attending the first ANC visit, and there are birth cohorts of HIV-exposed infants. In general terms, a cohort is defined as a population in which membership is determined entirely by a shared event and the members are followed over time. To walk through this definition for birth cohorts, as one example, the population is infants born to HIV-infected mothers. The shared event of the cohort is that they were born at the same time. So for the purposes of most paper-based records, this is really within the same month and year. We are interested in the final outcome of the infant at 18 months of life and or 6 weeks after the cessation of breastfeeding. Our main outcome of interest is the HIV status, or if no HIV status is available, the status of the child in care. So for example, if they were active in care, lost to follow-up, died, or transferred out before the final HIV status could be determined. To easily document and report on these outcomes of birth cohorts, this requires organization of facility-held records by birth month of the infant. So the purposes of cohort outcome analysis are to permit evaluation of outcomes of the PMC program using paper-based M&E systems, highlight program quality concerns for intervention, and allow for comparison of data over time. So comparing comparing against the year of ART initiation and between groups of patients, between health facilities. Moving beyond cohort monitoring at the site level, the second recommendation was the need for combined review of B+ program data from both ART and PMC program managers and the use of shared data for decision making. So this is often easier said than done. One way to do this would be to create an integrated program monitoring technical working group, which includes representatives from both ART and PMTCT, as well as M&E officers. Another, probably more practical option would be to adapt and combine current and existing working groups. This group will need to review the recommended indicators, the data collection tools for ART and PMTCT to identify gaps and revise the tools. To effectively implement B+ programs, PMTCT and ART programs will need to collect and review data together at the facility, subnational, and national levels. So the third recommendation is to conduct enhanced monitoring. This is the collection of additional indicators from a sample of facilities to assess program quality and identify issues needing targeted intervention. Critical indicators to assess program quality during B+ implementation can be grouped into 4 broad categories. The first 2 are listed here. The next 2 will be on the next slide. But they are rapid testing quality assurance, stockout of critical commodities, early retention, and viral load suppression. The table here lists the categories, shortened names, and the rationales for each indicator category. The full indicator names, the numbers, and reference sheets are all described in detail in Table 4, page 25 of the document, as well as in the appendices. The first 2 indicators refer to monitoring of rapid HIV testing quality assurance, so correct implementation of rapid testing algorithm and participation in a proficiency testing program are important to minimize the likelihood that a false positive result would lead to initiation of a woman on life or child on lifelong ART in error. The third indicator refers to stockout of critical commodities, specifically monitoring if stockouts of rapid test kits, maternal ART, or EID DBS test kits are experienced at the site helps programs address stock management and distribution issues before they become crisis situations. The next 2 indicators capture early retention on ART. So early experience with B+ suggests a large percent of the loss to follow-up at 12 months actually occurs between the first ART initiation visit and the follow-up visit. Failure to return for the second may indicate poor retention or more likely may identify failed initiation of ART. The final indicator highlights the importance of measuring viral load suppression. viral load at 12 months after ART initiation serves as a biologic marker for ART effectiveness. Unsuppressed viral load can indicate poor treatment adherence and lead to both increased risk of mother-to-child transmission of HIV and poor health outcomes for the mother. So the number of sites for conducting enhanced monitoring is suggested here as a recommendation, with an emphasis towards the ease of implementation at purposefully selected sites. Countries can select more sites than recommended depending on capacity. The rationale really is to sample enough sites to offer a reasonably representative view of B+ implementation, while ensuring a feasible sample size for enhanced data collection, reporting, and use. Overall, the objective of enhanced monitoring is to fill the gaps of information collected through routine monitoring. And this brings us sort of to our final recommendation from the B.
What happened? No, but I said unmute. I didn't. Okay. Hello? Sorry, James, we lost you for 1 second. Continue now.
Sorry, did it?
No,
Can you hear me now?
I clicked on something by accident, but.
Oh, okay.
Yeah.
Where did I get cut off? I mean, I'm sort of at, this is my last slide, so I can just kind of
start. Yeah, you can start on this slide. Yeah.
I mean, the main point here is really just that ideally you're collecting information from a routine enhanced monitoring system, so it's that you can evaluate changes over time. But realistically, in the short term, many programs that are have rolled out B+ will need to do process and systems evaluations. Process evaluations use indicators developed by the program to measure program rollout. So they can validate the conclusions from routine monitoring, and they can collect additional qualitative information, so very importantly, client perspectives on B+. Systems evaluations review program monitoring tools to assess whether or not they are adequately monitoring the program. So basically, this is to identify gaps that would require modification. So just in summary, there are these 4 recommendations again. The PMTCT programs must move beyond coverage to look at ART retention and final outcomes. This would require cohort outcome analysis. They must, or we're recommending combined review of B+ program data by ART and PMC program managers. And there's a need for enhanced monitoring during implementation because B+ is a new service delivery model. And the last is to conduct process and systems evaluations in the early phases of rollout. So I just want to I want to acknowledge all the other co-authors of the framework, as well as all those listeners who have contributed to the presentation today. Thank you very much.
Thank you very much, James, for your brief but yet very informative presentation to give us an overview of the document. Again, I'd just like to remind everyone to kindly put your mics on mute because we're hearing some background noise. So please right-click on your microphone, which is next to your name, and choose mute. It can be very disruptive to the speaker and to the other participants. We are still hearing it, so please ensure that you're on mute before we continue. So as we said, we will provide 2 examples from Uganda and Kenya. And the first presentation will focus on Kenya's experience in implementing some of the strategies and interventions that are presented and proposed in the M&E Option B+ framework. The presenter originally was supposed to be the PMTCT program manager from the Ministry of Health in Kenya, but unfortunately at the last minute she had a conflicting priority and was unable to make the presentation. However, on her behalf, Brian Pasvakavambwa from WHO, who is the HIV AIDS advisor for WHO in Kenya, will deliver the presentation on her behalf. So as I load the presentation, again, please everyone just check that you're on mute. Brian, as we're loading the presentation, so feel free to take over as presenter so you can change the slides.
Okay.
Okay, yeah, sometimes It takes a little while. Okay. Okay. It's loading right now. Okay, there you go. Can everyone see the presentation?
Yes.
Yes. Brian, you see it? And if you
Yes.
click take over as presenter, you should be able to, yes, there you go.
Yes, it's now loading.
I can see it, yeah.
And then you can switch the slides.
All right,
How do
so
I
I
see
can
it?
start.
Great, yes. Feel free to start when you're ready.
Yes, thank you very much, Jessica, for the introduction. Again, I'm presenting on behalf of Rose Wafula. I'm hoping she's online. She was going to try and connect. Unfortunately, she was not feeling well and needed to rest. But she had promised she was going to try and connect because she will be answering all the questions. In addition to Rose, we should have online, I'm hoping, Ellie Benjamin from our CDC office here, and Agnes Langat, also from CDC Kenya. I'm hoping they've managed to connect because they will also be responding to some of the questions. So thank you very much. So I'll go over the presentation. So the outline of my presentation is I'll quickly give the context, the Kenya context with regards to HIV and PMTCT. We'll talk about the PMTCT program progress that we have made very quickly, and talk a bit about the option B plus uptake in the country since 2013. Talk about the retention on option B plus, looking at the PMTCT cohort analysis, and then move to PMTCT outcome determination using the HEI cohort analysis. And then I'll finish off with some recommendations and our conclusions and recommendations.
Brian, can I interrupt you for 1 second?
Yes.
Just if you could stay close to the mic because you're going in and out a little bit. So if you can ensure that you stay close, that'll enable us to hear you more clearly.
All right. Thank you very much. I think I'm trying to avoid the mess that I did at the beginning when I kept shouting, so I think I'm running away from the mic.
Yeah.
All right.
That's
so I think I'll proceed then to give the background, the country background. So our HIV prevalence has been going down. It's now estimated to be 6%, using the HIV estimates of 2013. The number of people living with HIV is estimated at about 1.6 million, of which 190,000 are children under the age of 14. We estimate that we have 1.5 million pregnancies per year, and we also estimate HIV positive pregnant women of about 79,000 per year, and the same number for HIV exposed infants. And this slide shows the progress that Kenya has made in terms of the PMTCT program from 2012. So you can see from the graph that our coverage, which used to be reasonable, well, it was still lower for mothers and much lower for infants, has gone up, and we now in the first half of 2015, our coverage is just over 2/3 for both mothers and infants. So we have made some reasonable progress. We changed over, adapted our guidelines, and in July 2014, that is when we moved to option B plus. The next slide shows the use of ART, basically option B plus, in pregnant women. And you can see on the graph there that when we look at 2013, the dark green is the number of women who are on ART, light green is AZT and single dose nevirapine, and then nevirapine and then interrupted ART. So you can see very clearly, since 2013, we have been able to scale up our Option B Plus program to this year, when we look at the first half of this year, when basically almost all mothers started on Option B Plus on ART, 98%, with still a very small proportion of AZT and single dose nevirapine, with single dose nevirapine tail. At the bottom of that slide, you see the viral load suppression rates between November 2013 and June 2015. And so you see the numbers for adults and then the numbers for pregnant women. So you notice that the numbers for pregnant women are quite small. So we have challenges with regards to viral load testing for pregnant women. The suppression rate is still not so good, around 85%, both for pregnant women and adults. But as I said, the pregnant women, our numbers are quite low. The next slide, I will now go through the maternal Option B Plus cohort analysis pilot project that we have been doing here in Kenya. So in terms of the background, so I'll give a bit of a background of the pilot project. So the background is the aim is to determine the retention of the mothers on ART, and this was done in 35 pilot facilities. In most of these, as you can see, the levels are indicated. Most of these are district hospitals, county hospitals, what we call them now, and health centers. And then we have so in this program, new positives and non-positives were put into the same cohort of the month once they were started on ART. So obviously for the newly positive, they would be identified and then put on treatment, whilst the non-positive, the first month that they are seen in the clinic is when they get into the cohort. And then we looked at the outcomes at 3, 6, and 12 months, and the data is presented for quarterly cohorts, the course that we looked at in January to March 2015. And the data was abstracted from the ANC registers and the ART registers in MCH. And on the right of my slide, you see some of the definitions. I think KP and NP I have explained already. The enrollment into the cohort, so PMTCT women were entered into a particular monthly cohort in the MCH ART register. And this included the non-positives and the newly identified positives. And the defaulter definition is the standard definition and the loss to follow-up. And I think those stopped and those suppressed. So for suppression, we are using either undetectable viral load or below 1,000 copies per mil, because we have some facilities which use slightly different criteria. So either of those was used. The next slide now looks at the results, a summary of the results from the pilot project. So maybe I'll take you just quickly to understand the slide. So the first column, and this is looking at the cohorts in January, February, and March 2015. So the indicators that we looked at, which are in the first column, include the first one is those who are enrolled into the cohort. Then we have transfers in, transfers out, and then you then get the net cohort that we looked at. And then we also have the defaulters, those who are lost to follow-up, reported dead, those stopped, alive and active on treatment, and then the viral load, the retention and viral load indicators. And then the next 3 columns are now looking at the 3-month cohort, which is the cohort from October to December 2014. And you would then have the non-positives and the newly positives, and then the totals. And then at the bottom, you will see the retention levels and the viral load uptake and suppression. So you have that for the 3-month cohort, the 6-month cohort, and the 12-month cohort. Now, I will just quickly talk about the observations from this slide. So I'll keep the slide on so that you can be looking at it. You can see very clearly that when we look at defaulters, the number of defaulters go down quite significantly as the cohorts get older. Secondly, all cohorts, when you look at all the cohorts, you can see that the higher retention is more among the non-positives and lower in the those who are newly diagnosed. And just to note here that the bulk of the clients were actually newly diagnosed, so 47% non-positives. You also notice that the viral load uptake is quite low among pregnant women, those who are tested, and also the results. This may have something to do with documentation. It may be a problem with uptake itself, but we think it may actually be documentation that mothers are tested, but we're not capturing the data. Just to also highlight that to be able to get this data, we had some challenges with abstracting the data from the data sources because, as you may understand, we are still transitioning from the MCH model, to the MCH model of ART provision. So we are revising our tools, and there are some challenges with being able to extract this data. We also have challenges with incompleteness of some of the ART registers in MCH, partly explained by the transition that I've talked about. And we also do not have a standard national approach to option B plus cohort analysis. So that could explain some of the challenges we have with our data. I will now move to HIV exposed infant cohort analysis. This slide shows the card that we use, the HEI card, which is completed at each clinic visit. And then next is the HEI register, where the cohorts are then put in there by birth month. And then the summary of the clinical information by month can then be done up to 18 months. And then we then have the HEI cohort analysis tool that we use at 9 months to extract or to get the 9 months and 18 months outcomes. And we have, so the piloting was done in March to September 2012, and then the implementation started in 2013. The next slide, I'm not going to go into detail. It's fairly busy, but it's just showing the HCA flow chart, flow diagram, and showing you when we do the first review and the second review. Basically, first review 0 to 9 months, and second review 0 to 18 months. And the indicators are there, and I'm not going to go through them. You'll be able to look at them when you get the slide. Now, I would like to present the results in terms of the service coverage. So we had 1,094 sites reporting between July 2012 and March 2014. And this uptake is looking at the 9-month review for the July, that's that cohort that I've just explained. And now on the graph, just to orient you on the graphics, 2012 is in the bars for 2012 are in dark green, and then lighter green is for 2013, and then much lighter is 2014. And then I'll just orient you. If you look at the bottom, you will see the grouping of the different charts. So the first two graphics are relating to ARVs. The first one relates to the percentage of mothers who received PMTCT ARVs. and the second group relates to infants. The next bunch is looking at the first PCR, the percentage HEI tested with PCR at age 6 to 8 months, and those looking at the whole period of 0 to 9 months. And then the next group of 2 is looking at the antibody or confirmatory PCR, looking at the percentage eligible HEI tested with first antibody and results available. And then the second one, percentage of HEI tested with antibody with confirmatory PCR and results available. And the last one is looking at exclusive breastfeeding. So you can see from our results that when we look at the since 2012, when, for example, I'll pick the ARVs, our coverage increased from 89 to 93%. When we look at infants, we have been able to go up to 94%. With regards to HEIs tested with PCR at 6 to 8 months, we have been able to move from 79 to 87. With regards to HEIs tested with PCR and results available between 0 to 9 months, so I mean that's the whole period, we have very good coverage. And then when you look at the antibody confirmatory test, you see basically the same trend. Obviously, we started much lower with the HEIs tested antibody positive with confirmatory PCR, but we have been able to push that up. And then HEIs who are exclusively breastfed is still not very high. We're doing reasonably, but obviously we still have a gap. So I'd like to move to the next slide, which then looks at the results for the 9-month infant outcomes, which I'm not going to go too much into detail about because I think my time is I'm getting a bit behind. But I want to highlight the linkage to care at the bottom, the table at the bottom. And you can see that the linkage to care of those who are positive, you can see we have gone from 83% to 92%, which is statistically significant. And then when you look at 18 months outcomes, again, you can see that we've made quite some progress from 83% up to 93% by the end of last year. I think I won't go into detail again with this. I think you can look at it. It's just showing the HCA monthly 2 that we use. And this is one of the examples from the January HCA. So I think the details are there. So when you see the slide, you could actually go through it. But I don't think I will need to go through it in detail. So I will then move to the recommendations then for the maternal option B+. So based on our findings and the work in Kenya, there is need to address the challenges. I think we clearly highlighted the issues we have with documentation of PMTCT services. So that's one area that we are going to work on to improve the monitoring in the context of option B+. And actually we have a whole initiative to begin to do that. So and we need to pilot different approaches to cohort analysis to ensure that this actually will be able to fit in the facility B+ implementation approaches, because it's clear that different levels we may not be able to do the same way of doing things in the different levels, and then be able to provide standardized cohort analysis system and tools as part of our cascade. We need to strengthen strategies for retention because we do have a gap with retention, such as tailored psychosocial support package for PMTCT mothers. We also need to address the issue of loss to follow-up and defaulters that are identified during cohort analysis to make sure that we actually follow them up and bring them back into the system. So we actually have a whole initiative to now do that for the whole program. And then we need to accelerated initiatives to address the issue of low viral load testing that we have at the moment. And then the second from last slide looks at the HEI cohort analysis, looking at the conclusions and recommendations. So with regards to this, we need to pilot. I mean, it's clear that the piloting that we did on the HEI cohort analysis was very successful. And actually, we've been able to learn from those experiences and we are in the process of scaling up, and we are making good progress. The use of HCA, clearly from the data that we presented, has shown statistically significant improvements in the uptake of HEI services and outcomes for infants over the last 3 years. It's as important, it's quite important for us to be able to do that to improve quality of care. The routine, we've shown that routine facility-based HEI cohort analysis is feasible and is quite useful in evaluating and improving program performance. Some of the next steps, so there are more steps that we could put in, but we want to just highlight two. The first being the integration of HEI cohort analysis within the national reporting tools, because the tools that we are using are not still national tools, so they have been specifically developed for this, but we need to integrate them into the routine tools that we use. And then lastly, we need to look also at those tools. There are many more indicators, and we will need to identify critical indicators that we could include into our system for upward reporting. And then the other indicators would need to be used as for QI at the facility level. So I would like to finish off by acknowledging the Ministry of Health, both at national level, the National AIDS and STI Control Program, and then county, sub-county, and facility level teams were obviously critical. The UN, WHO, UNICEF, and UNFPA, which provided support in this process, and our partners, the President's Emergency Plan for AIDS Relief, PEPFAR Kenya, including the different agencies, CDC, USAID, DOD, implementing partners, ECPAF, and AFIA, and Western Kenya, where some of the work was actually done. So thank you very much. I think the team will be ready to answer the questions. And as I said earlier, I'm hoping Rose is online to answer all the questions. But Ellie and Agnes, I hope they manage to connect so that they can answer the other questions. Thank you very much.
Thank you very much, Brian, for a rich presentation that discussed the results of a pilot cohort analysis for both pregnant women and HIV-exposed infants, and also provided some programmatic recommendations that Kenya is exploring based on the results of the cohort analysis, and that other countries can also learn from. We've received a question from Fatima, so just to let you know, Fatima will answer that question in the Q&A session. It's just a point of clarification, but we've noted it. And for the Kenya team, if you are online, please let us know so that when we arrive at the Q&A session, we can you can also field some questions. And without further ado, we also have an exciting presentation from the team in Uganda. And we are loading the presentation now. So our two presenters are Dr. Linda Nabitaka, who is the M&E officer for the PMTCT program with the Ministry of Health. She has over 14 years of experience managing and providing M&E support for public health programs at all levels of the health system. And she will be joined by Dr. Moses Walakira of EGPAF, who is a public health specialist with more than 12 years of experience designing, planning, and managing HIV/AIDS programs at the district and national level with various organizations such as EGPAF, UNICEF, and AIDS Relief. So with that, we hand it over to the Uganda team. And Dr. Linda, feel free to start when you are ready.
Okay, thank you. I hope we are audible.
There is a slight echo.
Hello?
So,
Hello?
yes, there's a slight echo, but if you can get close to the mic, that might help.
Okay. Thank you very much.
Yes, that's
Are we
much
audible?
better. Very good. Thank you.
Okay. Okay. So this is the Uganda team. This is Dr. Linda starting the presentation, and I'll be joined by Moses. So we are presenting on implementation of early retention monitoring for HIV positive pregnant breastfeeding women and data use in the PMTCT program in Uganda. This is our outline, background, methodology, issues addressed, challenges, documentation, lessons learned, and recommendations. A little background on the Ugandan context. We have a population of about 35 million people with the HIV prevalence of about 7.3, general prevalence of about 7.3, and 8.3 in women and 6.1 in the men, according to the AIDS Indicator Survey of 2011. HIV prevalence among pregnant women is about 5.5 from the same survey. We have about 1.6 million people living with HIV. HCT access in antenatal is about 98%, and as of last year, about 85% of all positive women attending antenatal receive ARVs. First antenatal attendance is about 97%, but declines to about 48% for fourth attendance. Fertility is very high at 6.2. Postnatal attendance is low at 33, and skilled attendance at birth is about 59, while exclusive breastfeeding for the first 6 months is about 62%. We were asked to define some of the terms that we use as Uganda. Retention is generally continuous engagement from diagnosis into care, and for ART specifically is for those means that those who are alive and on treatment, and this is measured at specific time periods. So in Uganda, we used to measure it at 6, 12, 24 months, up to 72 for the ART program, but we are now also making it at 1, 2, and 3 months for the PMTCT. Then lost to follow up or dropped is when a patient receiving ART is not seen for more than 90 days after their last scheduled appointment, and attempts have been made to contact this client, but we cannot find the client. Lost means that the person has not been seen in the last quarter, but was scheduled for visit. While appointment keeping means that if the client has kept their appointment, that means they came on the same, either on the day of the appointment or before the appointment or within 7 days after the scheduled appointment. So Uganda started implementation of option B plus in 2012, and as shown in the graph on the right upper corner, the number of pregnant women initiating ART has dramatically increased over the years. That is the gray area, from a very small percentage of 0 point something to 41 to over 56% in 2013-14, and we are hoping that by this year all women will probably be initiating ART. However, an assessment done in Uganda in September 2013 demonstrated that 20% of women newly initiating ART never came back after the initial visit, as shown on the graph in the lower. So the mother-baby points, so as to be able to facilitate mother-infant pair follow-up. But at that point, we did not have any specific M&E systems to track the results. So with support from PEPFAR through EGPAF, Ministry of Health piloted early retention monitoring and the rapid district response in 30 facilities across 5 districts to address some of the issues, including monitoring early maternal ART retention, improving retention to PMTCT risk period, enhancing follow-up of mothers and babies to the end of PMTCT, ensuring appointment keeping for mother-baby pairs, supporting data collection and reporting by health workers, improving data use for improved performance through monthly review meetings and use of quality improvement initiatives at site level, and supporting oversight, mentorship, and support supervision by the district and Ministry of Health at regular intervals. So generally there were three major issues that we did. The first one is establishing real-time monitoring, where we developed a maternal ART retention monitoring data collection and reporting tools, as well as a dashboard to show performance from the sites. We then instituted site-level quality improvement initiatives and strengthened the facility quality improvement teams with focus on mother-infant pair follow-up, and then supported district oversight by establishing a system of district response teams using the existing quality improvement structure and focusing on identifying and prioritizing critical issues from the weekly reports and facilitating corrective action. So in real-time monitoring, we developed 5 indicators on retention at 1, 2, and 3 months, as well as appointment keeping for mother-baby pairs. These were incorporated into the weekly reporting dashboard, which had already been started at the beginning of Option B+, and these are reported on monthly from the implementing sites. I haven't gone through that, but that's how they are. So this is the national dashboard for weekly reporting. Under the weekly reporting, which was established as soon as we started Option B+, we used to look at issues like facilities without ARVs. For example, in that particular week, there were 2% facilities which had no ARVs, which came to about 40 facilities. Then facilities without test kits, and in that week there were 10%, which was 172. Then number of mothers who had missed their appointments were 932 in that week. Then for EID, there were 1,675 tests done, out of which 60 were HIV positive, showing about 3.6%. Also in that week, from the clocks above, 86% of facilities actually reported, 88% of women were tested for HIV, and 84% of women were initiated on ART. So this weekly dashboard has been in existence since we started Option B+, and this reporting comes from all the facilities that implement Option B+ through an SMS sent at the end of the week. So to that, we added the retention indicators as shown, where we report number initiated in a month, then those that are retained after month 1, month 2, and month 3. And for this particular cohort that was started in October 2014, 162 were initiated. Out of those, 128 came back for month 1, which is about 79%. Then in month 2, 1 mother was followed up and came back, so 129 were then seen, while in month 3, 119 mothers came back for the 3rd month, showing a loss to follow up of about 27% over the 3 months. So that shows 43 mothers overall from the 6 districts were actually lost. So this is the dashboard that is seen centrally and by all the implementing sites, and then each of the sites is able to do follow-up of mothers that have been lost. This is now just showing the dashboard by one district. So in that district, for that particular month, 38 women were initiated, 26 came back after the 1st month, then some were followed up, so 33 came back after the 2nd month. Then because of the activities that were done at the facility, then 36 were able to come back after the 3rd month. So only 2 mothers were finally lost at the end of the 3 months. And this is below shows the different sites that are reporting and how they are performing per month. Then the second issue that was done was site level quality improvement strengthening. In here, we strengthened the facility quality improvement teams. We modified client flows so that we can improve the way clients were flowing through the system. We reinforced documentation because it's a big issue at the facilities. We improved the use of appointment books so as to identify missed appointments of HIV positive pregnant women and mother-baby pairs. And then we incorporated methodologies for continuous monitoring of retention and tracking loss to follow-up clients. So the picture shows a discussion on quality improvement initiatives by a team of Ministry of Health and district supervisors at the end of a month. Then the third thing we did is strengthening district oversight through the district response teams. So we established a system of district response teams, and we used the existing district health team and their quality improvement structures so that they look at the two dashboards, the weekly dashboard and the monthly dashboard, and they identify and prioritize critical service gaps from the weekly reports and the monthly reports, and then facilitate corrective action, and they track success of interventions. So we conducted trainings for these teams on how to collect retention data and how to understand, analyze, and use the data. Then we strengthened the capacity of health facilities and district health teams in data use for planning through mentorship and support supervision. And then we developed a coaching tool and district data toolkit to guide mentorship. So Moses is going to take over to take us through the rest of the presentation. Thank you.
Yeah, thank you, Linda, for the presentation so far. This is Moses Walakira. Linda has taken us through what we did, and briefly you've seen the dashboards and the other data sets that that we have. So we actually realized that this data was generated, it was accessed at different levels, at the health facilities, at the districts, at the national level, and many of the implementing partners had access to this data. But there was limited use of this data to inform the program implementation. So what we did was to develop a district data toolkit. This is a toolkit that would guide the capacity building and training of the district response teams to be able to develop capacity in analyzing the data and guide the subsequent support supervision. So this slide shows a bit of the content within that toolkit. The first module focused on prioritizing the data that is got from the weekly Option B Plus dashboard that you saw. And using this data, the district teams would prioritize issues identified in the analysis by analyzing this data at the district level. And then the second module looked at the retention data that was being submitted by the pilot health facilities. And by using this tool, they would prioritize issues identified in the analysis of the monthly reports that were being submitted through the dashboard that you've seen. And then the third module was the calendar schedule. This tool helped us to set the site schedules according to the priorities identified in the prioritization matrix. And then the fourth module was the facilitated data summary feedback form. You realize that the health workers submit this data by SMS, but they would hardly get the feedback from the from the district response teams or the district management teams. So this form was used to summarize the feedback to the health facilities, and it was site-specific feedback, trying to highlight the issues that are being noted from the data that has been submitted by the respective health facilities. And then the fifth module looked at the action item tracking. This tool is basically used to track the implementation of the action plans that have been developed by the district response teams. And they keep on updating this tool to help them tick off those activities or those action items that have been implemented. The next slide looks at some of the results and successes that have been registered from this activity and from this pilot. We noted that early maternal ART retention indicators that we saw that track retention at month 1, month 2, and month 3 were feasible to collect and also report using a simple SMS mechanism. And 3 months retention from this graph on the right-hand side increased from October when we started this exercise from 74 to actually 90% by March when this pilot was actually concluded. And we also saw that we needed about 3 months of learning and change period for us to be able to notice marked improvement in some of the indicators that we are tracking. Maybe I would love to say that at this point in time, the first 3 months focused a lot on strengthening systems at the health facility level. A number of documentation, a lot of documentation in the various tools at the health facilities was not happening as expected, and a number of other systems like the client flow and appointment systems were quite weak. So there was focused attention in the first 3 months to strengthen those systems, even before moving to the interventions to help us improve the retention tracking at these same facilities. While implementing this pilot, we noted some varying challenges that affected the pilot. The first one was related to documentation. We noted that health workers were not supervised as expected before to ensure completeness of the data entry in the multiple tools that were available at the health facilities. We also noted that because of the multiple tools and because of the shortages of health workers at different health facilities, and also coupled with the frequent transfers and rotation of health workers within districts, this affected the continuity of service delivery. Also, the other key challenge that we noted were the poor client flow at most of the health facilities that actually interfered with the efficiency of service delivery and data capture in the various tools. We also noted that the preferred method and the easiest method of tracking clients was the mobile phones, but majority of the health workers, about a half of the clients didn't have mobile phones, and this made the client follow-up using the phone numbers quite challenging. There was also poor accessibility in some of the areas, especially in the islands and also some of the communities during the rainy seasons. And there were still issues of stigma and non-disclosure among the identified post-pregnant and lactating women. That was a big challenge at a number of health facilities, and which eventually impacted on retention. The next slide focuses on some of the early lessons learned from this pilot. The first set of lessons were related to real-time monitoring. We noted that many of the districts using the MPAC system, which is the M-Health mechanism established by the Ministry of Health, send reminder messages to health workers to be able to submit the weekly and the monthly reports. And this was very critical to improve the reporting rates for almost all the health facilities that participated in this pilot. And the other lesson was that continuous support in documentation, especially through the supervision and mentoring of the district response teams and Ministry of Health mentors, was critical in improving the data quality, actually minimizing the errors between what the health facility submitted and eventually what was validated. The second category of lessons are related to functionality of the site level quality improvement teams, and also the different improvements and the different projects that were set up. we noted that pairing of clinical charts for both the HIV positive mother and the baby, and also writing the identification serial numbers for both the mother and exposed infant in the appointment book, facilitated coordination of the appointments for the mother and the baby. And this, coupled with ensuring that the mother and the baby appointments were synchronized, actually improved the adherence to the appointments that were given. But also it is important to note that the use of the different cadres of volunteers at the health facilities and the communities, like the village health teams, the peer educators and the linkage facilitators at the health facilities, facilitated client tracking, especially those that had missed appointments. And the use of the quality improvement documentation journals and setting up quality improvement projects to summarize the weekly option B+ reports and monthly retention reports facilitated tracking the performance at these health facilities, and it was very clear to all the implementers where the gaps are. So they were able to identify gaps and also come up with possible solutions that were being implemented. And the third set of lessons around the district oversight, especially related to the district response teams. The district response teams actually benefited from the intensive coaching and the support to review and analyze the weekly reports and also the monthly data that was coming in. And through this exercise, they were able to build their capacity to be able to prioritize those health facilities that had gaps and also tailor the interventions to address those gaps. It was also noted that the districts were able to come up with the weekly district health team meetings, and through this platform, they were able to discuss the data from the weekly and the monthly reports that was coming from the health facilities. They used this platform to identify and prioritize gaps, but also to develop and tailor the support supervision and the mentoring plans to guide the implementation and the support to the health facilities that had major gaps. From this exercise, we were able to come up with a set of recommendations. And the first one, we noted that is actually important to maximize on the existing efforts to monitor both the early and late retention of the HIV positive pregnant and lactating women, but also the mother-baby pairs. And it is critical for us to be able to for closer retention, monitoring, especially in the immediate period after initiating the women on option B+ on ART, and also during the risk period with the continued breastfeeding due to the shortened period of adherence counseling that these women get. In Uganda, what happens is the fact that as soon as the mother has been identified positive, she's prepared and initiated on ART the same day. There is also need to define interventions to target points along the cascade, especially where there are greatest losses are occurring, and also support the health workers to implement these interventions. It is also important that we strengthen data use for improved program implementation with focus on using the quality improvement approaches and initiatives. And we also noted that working with the district leadership and also Ministry of Health leadership is actually critical in cultivating the culture of ownership and sustainability. We can actually see that this pilot was concluded in March, but these same health workers, because of the support from the district teams, have continued to submit reports, and the district response teams have continued to use this data to guide the retention efforts at the health facilities. It is also important to continue with the capacity building activities, especially mentorship and supportive supervision. And we also noted that effective engagement by the implementing partners is critical for the successful implementation of any new program initiatives. And the community structures, including the family support groups, VHTs, and peer mothers, are critical in supporting service access and retention efforts if they are to be undertaken. In conclusion, because of these initiatives and the pilot efforts, Uganda has been able to successfully begin the real-time monitoring of early retention of mothers on option B+, both the pregnant and lactating women. But also, we have a set of lessons that we can put to scale to cover the rest of the country. And system improvements will continue to be made, but also starting October this year, we are planning to roll out the initiative of early retention monitoring countrywide, together with the implementation of other critical areas within the PMTCT program, especially the B+ M&E framework that includes birth cohort monitoring and NAMC cohorts through the use of the longitudinal registers. Thank you so much for your attention.
Thank you very much, the Uganda team, Dr. Nabitaka and Dr. Walakira, for your enlightening presentation. I think we've noticed by the nature of the questions that there's a lot of excitement around the real-time monitoring of stockouts and retention, as well as the quality improvement initiative that you've been able to implement. And we've noted all the questions, and we will address them during the Q&A session. Prior to moving to the Q&A session, Nande will provide a recap of the main points of both presentations to orient us and frame our discussion. And then we will move on to the questions on a first-come, first-served basis, and group them where appropriate based on theme. So over to you, Nande.
Thanks so much to Jamie, Brian, Linda, and Moses. These were very exciting presentations, and we can sense from the comments and questions that they have been very well received. Just to recap, Jamie highlighted 4 recommendations coming out of the B+ M&E framework. The first being that PMTCT programs need to move beyond coverage to look at ART retention and final outcome using cohort outcomes analysis. The second is that we need to have combined review of data by ART and PMTCT program managers. The third, that we need to now begin to implement enhanced monitoring. And the fourth is that we need to conduct process and systems evaluations in the early phases of rollout of B+. Kenya gave us great examples of cohort analysis, both from the mother's perspective and the infant's perspective. For the Maternal B Cohort Analysis pilot project, they were able to demonstrate retention rates at 3, 6, and 12 months. And they also observed higher retention in known positives and reducing defaulter rates as the cohort matures. For the HIV-exposed infant cohort analysis, this is a system that has been in place since 2012. They presented results from 2012 to 2014. And over time, they've observed increasing coverage for pediatric HIV indicators and an increase in the number of infants that are active and in follow-up at 18 months of age. Uganda gave us an exciting example of an enhanced retention monitoring system, which they referred to as early retention monitoring and district response monitoring. It had 3 components: real-time monitoring by SMS reporting, site-level quality improvement, and district oversight that is informed by dashboard review at weekly and monthly intervals. The key areas of focus for this enhanced monitoring system were on early maternal retention and commodity stockouts. They were able to demonstrate results at sub-national level down to facility level and showed us examples of the dashboards that they use. And they showed results which reflected increased 3-month retention from 74% to 90%. Both Kenya and Uganda shared their challenges and were able to give us concise lessons learned and recommendations going forward. So with that, I think we'll go straight into the Q&A session that Jessica will lead.
Thank you, Nande. So I think we will address the questions by country, and then where the questions are general and cut across both country teams' presentations, we'll address those following this questions that are specific to each country example. So first, starting with Kenya, one of the first questions was a point of clarification submitted by Fatima of ICAP in New York, and her question was to clarify whether the known positives and the newly diagnosed positives in the ART cohort were women newly starting ART. So just to clarify that these women do not include women who were known positives already on treatment. So over to the Kenya team to respond. Brian, are you there?
Yes, hi, how are you? Rose, it sounds like Rose is not online, so I think we will respond. The newly positive were obviously the women who were identified in ANC. The non-positive include those women who were they could either have been on ART or they may not have been on ART. But looking at our data, most of the women who were non-positives, I think the number is about 80%, were already on ART. So I hope that's clear enough. Thank you.
Okay, great. Thank you for the clarification. And Fatima, if you have any follow-up questions, please let us know. The next question was from Priscilla Adele of UNICEF regarding viral load monitoring. So is viral load monitoring standard practice? And why do you think that viral load uptake was so low among pregnant women? And Brian, to let you know, I think that Agnes is on the line as well as the CDC team from Kenya. So if you'd like to also, for them to address some of the questions, feel free to delegate the questions to them as well.
Yes, I have Chris is here now. Chris Omar from UNICEF. So again, the CDC team is there. Can you please just repeat the question? Sorry.
Sure, sorry. The question was regarding viral load monitoring. So is viral load monitoring standard practice, and why do you think that viral load uptake was so low? Based on the data you showed, viral load uptake was low among pregnant women. So what are possible reasons for that?
Yeah, Chris will respond.
Okay, I think this will need both a response from me and from CDC. The access to viral load in Kenya is still problematic, and currently we've been relying on CD4 testing, and the viral load rollout is just occurring. So we are yet to fully implement that transition. But I don't know if Agnes has anything to add on that.
This is Helen
Agnes,
from
you want to add
Kenya.
something? Yes, Helen, please.
Yeah, this is Helen from Kenya. Viral load testing was scaled up to routine from end of 2013, 2014. So the whole of 2014, we actually spent time to really build the capacity for viral load testing for Kenya. And by now, I assume really we are still scaling up. And I think most sites today have access to a viral load test. In 2014, we spent time to develop a Kenya strategic plan for viral load testing and really map out the labs that are currently build their capacity for viral load testing. We have two platforms, mainly using the DBS viral load for DBS sample for sample transport for per sites, and whole blood and plasma for the other sites. So we feel confident that probably this data was really at a time when the scale up was still happening. But right now, I think we have fairly good access for viral load testing, and we hope that actual patient access to date should really be improving or should improve. And hopefully within the next 1 year, we should be able to really stabilize for viral load testing and have even systems to be able to routinely monitor viral load testing. Just a very big plus for viral load testing for Kenya is the fact that we actually have a web-based system for recording all viral loads done, and sites are able to look at their viral load tests online and really get their results. So, you know, we probably have a very robust system. So it's just the fact that it was really like at a scale-up phase at the moment that this data was being looked at. Thank you.
Yes, and maybe can I just add one more point?
Sure.
So also the countries we're in the process of scaling up. We've actually developed a plan that's being finalized on scaling up viral load testing, so that we're going to increase the capacity for testing, even though it's already available. Thank you.
Thank you. So thank you very much. So the next question is regarding the denominator used to calculate the retention rate of both women, and also the denominator to calculate the HIV-exposed infants tested with antibody tests. So can you describe how those denominators were calculated?
Yes, I think Agnes will
Okay, this is Mary from Kenya. I can respond first to the denominator for HIV-exposed infants antibody testing. And for that indicator, we used all of those infants that were eligible for a 9-month antibody test. So that would be the total number of HEI registered in the cohort, less any infants that were identified positive previously, because we assume they would have been transitioned out of HEI follow-up, put into HIV care and treatment services, or any infants that had transferred out or had had a known death before the time that they had that they would have been, you know, receiving an antibody test. And we use a similar kind of formula for 18-month antibody testing. So it's really a denominator was all of those infants that were eligible to have an antibody test. Now for the mothers, I think we'll have to just consult to get the exact answer. But I believe they used a system that's similar to a standard kind of ART cohort summary, you know, analysis. I think many of you probably even recognize the format that pilot took. And in those cases, I believe they have a net cohort that they use where you have, you know, the original cohort less any transfer outs between the time of start of cohort and the point of assessment, and plus any transfer ins. So I am, again, we'd have to confirm, but I believe that's the denominator that they would have used as a net cohort at the time of assessment. Thank you.
Thank you very much. So 2 more questions for Kenya specifically, and then we'll move on to Uganda, and questions that apply to both countries. The next question is, could Kenya share with us best practices that have contributed to the gradual improvement in the HIV-exposed infant cascade outcomes over the years? And then I'm going to add a second question to that, so we address them both at the same time for the sake of time, as we're approaching the end of the webinar. How did you treat women who were known HIV positive but already on ART when they booked at ANC for the same period of the cohort analysis? So again, how was the gradual improvement in the HIV-exposed infant cascade achieved over the years? And then second, how did you treat women who were known positive but already on ART when they booked at ANC for the cohort analysis?
Brian, do you want us to answer?
Yes, please, Helen, if you can answer, I would add if necessary. Thank you.
Okay, so for I'll just take the first question. Best practice for really improving HEI outcomes over the years. I think for us, just the first step of really being able to document outcomes was very critical and key. because previously sites did not even know what the outcomes for the HEI were. So really having each site to be able to document and be able to really assign an outcome to an infant was very critical. Then we also had targets for achieving each outcome, so that, for example, the lost follow-up target was really there. How, you know, what's the target for retention? So that really helped. The other thing is, through the HEI cohort analysis, we have a format to be able to, for sites to be able to assess their performance and come up with action plans for improvement, and is part of the whole HEI cohort analysis. So that also really helps sites to, on a monthly basis, look at areas they didn't do well, and then come up with, you know, improvement plans, and, you know, help the process to improve. The other two key things that we think really helped is Kenya currently has really integrated infant care into the overall maternal child health, and I think that's really, and also ART, so that really has helped in terms of making sure, you know, there's a one-stop shop, everything is offered at the maternal child health, and also once infants are identified HIV positive, it's fairly easy to link to ART. We also have mentor mothers at sites and peer educators who really help to offer lay support in terms of looking at, you know, tracking retention and also default tracing. So we thought really a combination of all these things has helped to improve outcomes for infants. For the mothers who are on ART and non-KP, and I'll just answer that in the context of the overall ART cohort analysis that Kenya is currently doing. I think about, I would estimate about 40 to 50% of women who we are seeing pregnant in our maternal child health clinics are actually mothers who know their HIV status, and a big proportion, I would say probably almost 80 to 90% of those are on ART. So it's really a big percent. Most of these, when they are on ART and they come into the cohort analysis, then as earlier mentioned, they are aggregated into one, because a lot of them really probably started ART at different times, some of them 5 years, 2 years, 1 year. So all of them would then enter while on ART and are put into one cohort, and therefore at that point then you are able to really look at the viral suppression rate at the time that they are entering into ART. So I hope I've answered both questions. I don't know if there's anything. Thank you.
Maybe I could just add on the second question, just quickly. Basically then, for the cohort analysis, I think as she has already said, those women who were non-positives and were on treatment were still enrolled, continuing on their ART, and those who were not on ART were then started on ART. And as I said earlier on, approximately 8% of non-positive women are already on ART when they come in. I hope that fully answers the question. Thank you.
Thank you very much, Kenya. And we are moving on now to Uganda, and especially for the sake of time. And there were a series of questions regarding the real-time monitoring through SMS, and there was an exchange between some of our participants, and I believe Edward in Uganda was responding, so perhaps the Uganda team can give a very brief synopsis of how the real-time monitoring works. Does someone want to just clearly describe in a little bit more detail how it works? And I believe it is accessible online, and we can provide that link so that all participants can look at it more thoroughly after the webinar. So there were questions regarding the cost, how the frequency, how it works. So does someone from Uganda want to take that on?
Okay. Thank you very much. So this real-time monitoring is done through SMS sent from the health facility, and this is seen centrally and flashed on the dashboard. It comes through the M-Track system, and the SMS is free at the health facility. So at the end of every week, there are 9 indicators that are collected on testing, initiation of ART, stock out of ARVs and stock out of kits, and then missed appointments. Each indicator is given a code, and once the health worker just writes the code and the number, and these come to a server at Ministry of Health, and then the report is collated per facility per week, and it shows performance of that facility per week. And then that's the dashboard to which we added the monthly retention monitoring. Again, at the end of the month, by the 7th of the month, the health facility workers send an SMS through the same code. Again, it's free. And then this is shown at the dashboard, at the central server. Ideally, I think that is it. The issue of costing, because this is a shared effort, UNICEF was already paying for MTRAC, for surveillance issues to do with polio and all other things. The PMTCT just piggybacked on that MTRAC system that was already being paid for by UNICEF. All we just did is add the PMTCT dashboard that is reviewed on a weekly basis. At the moment, we are not so sure of the cost because everyone pays for a different section of the dashboard. I think essentially that answers on the real-time monitoring.
Okay, great. Thank you so much. And the next question was regarding different strategies used to monitor retention at different level health facilities. For example, what are the strategies used for addressing loss to follow-up at higher level facilities versus lower level facilities, given the difference in retention rates between them?
The strategies actually are the same at all the different facilities. The only difference, and there's closer monitoring by the implementing partners at those facilities because they have a bigger number. So at all facilities, ideally, family support groups that meet monthly and are able to look out for each other. At the bigger facilities, the family support groups are bigger, and therefore they meet more often, and they have closer monitoring. We also support the use of phones, so that for mothers that have phone calls, they're able to, they have phones, they're able to make phone calls for these mothers. And we also support home visits for some of these mothers. Also, in some of the implementing areas, at these bigger facilities, we have the mentor mothers, and these mentor mothers also support closer big facilities. But ideally, the strategies used across the facilities are
Hello? Hello?
We can hear you.
Okay, I think we lost.
Yeah, we're waiting for another question.
Oh, okay, sorry, you tuned out. It was tuned out for a while. So the next question is regarding, it's really for both countries, and it's regarding community mobilization and community perspective. So how can this framework be implemented in the community outside of health facilities? And what community mobilization strategies were used to increase enrollment in option B+ and to reduce loss to follow-up?
At the beginning of the... Hello? Hello?
Hello?
Yes, I was responding to that question.
Hello?
We tried as much as possible to engage multiple stakeholders engaging, ranging from political leaders and leaders at various levels at the district and also up to the community level. But then the Ministry of Health has a village health system structure where the village health team members directly engage with the community members. So what happened is that the Ministry of Health developed a community resource persons curriculum. And that's a curriculum that is intended, or it was intended, to guide the VHT activities, educate the communities about PMTCT, EMTCT, about the new guidelines, but also help them to respond to some of the common questions and myths around EMTCT. So we did orient the village health teams on using this curriculum to capacitate them to be able to address most of the related challenges communities, but also we are using the village health teams in tracking some of the clients with missed appointments without necessarily revealing the HIV status of these clients. So a number of the health workers have stronger facility community linkages, and they have monthly meetings with the village health teams where they review performance of the village health teams, and the village health teams also share their reports. So you realize that using that platform, they has been able to facilitate the linkage process, but also in terms of minimizing the costs for tracking clients in the communities, we have explored that opportunity to use the village health teams to track some of the clients that are lost within, along the PMTCT cascade.
Hello. Hello.
Yes, can you hear me?
Yes.
Is there anything to add?
Yes. Can Kenya respond?
Sure.
Yes, for Kenya, I think we'll ask Helen to respond if she's online.
Most of the tools, most of the cohort tools that we are currently using are actually facility-based. However, we still have specific programs that link back to the community. One key component that links back to the community is the full tracking and retention strategy, where at facility level we have actually fairly robust tools for making sure that we are able to track all appointments. There are mentor mothers or peer educators who actually have specific tools that will be able to track every mother to make sure they keep appointments and really even support home visits when needed for either adherence or default tracing or retention support. So those are available. Additionally, in terms of really supporting access to ART services for mothers who have not even come to the health facility to seek HIV services, we also have different strategies that have been tried out. Previously, we've used like the community strategy. We have community healthcare community health workers. We also have in some facilities mentor mothers who really are able to support women who stay at home to really access services within health facilities, and hopefully that has really improved in terms of just increasing the ANC uptake. Which for Kenya, first ANC uptake is actually fairly good, and what I think we are really trying to improve is retention through the cascade, and also retention right from attending the first ANC, delivering at a health facility, and really retention through the 2-year period for the infant. So that's probably the areas that we are really working on and trying to strengthen. Thank you.
Yeah, and Chris will just add 1 point. Thanks.
Yeah, just to mention that the government of Kenya is rolling out a reproductive health and maternal health scorecard. And the scorecard keeps track of important indicators right from childbirth until looking at childbirth, early childhood, adulthood, looking at the community and health systems indicators. And what we are planning to do is to ensure that some of the community health unit monitoring tools are able to feed directly into the scorecard. This is something which we can share, and we hope that this can become part of our best practice for community health.
Okay, thank you very much, Chris. For the last few questions, which apply to both countries, I'll ask these questions, but then there are others that we might not be able to get to, but we will make sure to follow up with the country teams and include it in the webinar summary if that's satisfactory for everyone, just for the sake of time. So the last three questions are as follows. The first is, how did you manage data collection and follow-up between ANC, labor and delivery, postnatal care, and maternal and child health services throughout the continuum of PMTCT care? So that's the first question for both countries. And then how are the results being used to inform further improvements at the site level? So the results from the interventions that were presented by both countries, how are these continuously being used to improve performance at the health facility level? And then lastly, could you tell us what kind of support you received from the government sector and how it was procured? Though I think both interventions were led by the government, I think this question is really getting maybe at financial support. So if both country teams would be kind to address those questions before we wrap up the webinar, and any remaining questions we've noted, and we will address them in writing following the webinar. Do I need to, should I repeat the questions?
Please repeat the question.
Okay, so the first is regarding data collection. So how was data collection conducted at the various service delivery points? So from ANC to labor and delivery and postnatal care throughout the continuum of care along the PMTCT cascade. So that's for both countries, as well as how are you using the results from the interventions you presented to continuously improve performance at the health facility level? And then the third is regarding what type of support did the government provide? And I think this question might be getting at financial support and how it was procured to carry out these interventions.
Okay, so from Uganda, we have to say that data issues are still a big challenge because of the way the records and the patients flow. And that's where most of our mentorship is geared towards improving the records because antenatal is in one section and usually ART is also in another section. And yet the health facility has one ART register which is located in the ART clinic. So the mother is initiated within the MCH and recorded within the antenatal register, and also and then the mother's recordings are taken to the ART register within the ART clinic. But the card for the mother is kept within the antenatal clinic. And then when the mother goes to labor, the cards are still left within MC.
Uganda? Are you there? It looks like, okay. Uganda, you're going in and out. It's hard to hear. Can someone else from Uganda respond? But if not, hello? Can you hear me? Okay. So if not, maybe we'll turn to Kenya to respond.
Yes, I think I'll ask Helen if she's still on to answer the first two questions and partially the last one, then I could add. Helen, if you could please respond.
Yeah. So for the first question, I think the biggest strength that Kenya has is really, as said earlier, integration of all the services within the maternal child health, so that the only service that you're seeing outside the... Hello?
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 Yes. This is the Uganda team.
Okay. Kenya's responding, so we'll let Kenya finish and then we'll come back to you. Okay?
Yeah, so I was saying, I think the biggest strength that we have is integration of all the services for the mother and the baby in the maternal child health. So that really helps in terms of tracking and ensuring that, you know, the tools that are used and linkages are really integrated. The only service that I think is outside with the maternal child health is really delivery, where, you know, the mother has to go to a maternity unit to deliver, then come back for follow-up in the maternal child health. So that has really helped. We have, you know, I think fairly standard tools for documentation at the antenatal clinic, labor and delivery, and postnatal clinic, all standard registers and tools that are used. And also, we currently have standard tools for the HEI, including a HEI card and a HEI register. For the the actual cohort monitoring, for the mothers, Kenya previously had an ART cohort tools that were used, and this is what have been adopted now into mother cohort monitoring for B+. And the ART cohort, actually, Kenya has used it, I think, for more than almost 2 to 3 years now. So it's really adapting it into the B+ context. And also the HEI cohort now, I think, has been used since 2012. So for us, I think being able to integrate, assess outcomes across the board, we are really not able to currently link the maternal cohort and the infant cohort to that degree, unless for sites that currently have EMR. But at aggregate level, really, each site is able to assess their outcomes respectively. How have we used the results to really improve to improve service delivery? For the cohort monitoring for mothers, I think really that's essential, and really being able to use those results to look at, you know, retention levels at site level, and also viral suppression rates at site level. And currently, as you saw, this is currently a pilot, and we hope that from this pilot, Kenya will go ahead and develop robust tools to be able to, on a larger scale, support cohort monitoring for mothers, and then really also inbuilt systems to be able to use the results to improve performance at site level. For the HEI cohort analysis, as I earlier mentioned, that's already in place, and we can, you know, very clearly see results in terms of how the improvement in results have really been remarkable over the last 3 years. And we hope that in the coming years, and with national scale-up and integration into the national tools, that will really sort of also improve remarkably. For how we've involved the government of Kenya, most of the cohort monitoring has really been integrated using existing systems. So we've really not had new systems. So for example, for the mother cohort analysis, as I said, there's really already an ART cohort system in place. So the only thing that probably we will need to do post-pilot is to probably support actual training, actual additional printing of tools, and, you know, just the rollout. So hopefully that you know, does not necessarily require significant additional resources. Similar to the HEI cohort analysis, apart from, you know, so we used existing HEI cards and HEI registers. The additional resources that we currently, you know, required was really training and developing just few additional tools, and we've really managed to do that with the national team. And currently, actually, we are working closely with government of Kenya and the Ministry of Health to really look at how to scale this up nationally as an effort towards elimination of mother-to-child transmission. As Chris had mentioned earlier, Kenya is in a phase where we actually are supporting stock-taking exercise at national level and at county level, and we hope that the cohort analysis for both the mother and the baby will actually be integrated into that system. And this is fully driven by government, supported by government, with just support from the additional stakeholders. And we recently held a national stock-taking exercise, and we are currently supporting, a process to be able to do the same at county level and really be able to support and see. And that's part of, the scorecard that Kenya is, Chris mentioned earlier. And we'll really be able to look at performance across the board for PMTCT, including the outcomes for the mother and the baby, and really identify where the gaps are, how to improve those gaps, and really support each side to be able to reach a certain level for PMTCT. And we hope that that will really boost support towards elimination of mother-to-child transmission. I don't know if, the other team members may want to add, Chris or Brian or Agnes.
Yes, I wanted to just quickly add, I think Helen talked about the stock-taking meeting that we had earlier in the year. We are actually now in the process of doing a Bring Back the Mother campaign, which came out of that stock-taking meeting, where we clearly showed there were 17,000 women who were not accounted for. So currently we have this process going on in every county where they are reviewing their data. They are looking at all the data sources, including the cohort analysis, to identify mothers and babies who have not been accounted for, and then using the community systems, go out and actually trace them and bring them back. So this is a 3-month campaign that we're doing, and then through it we are building also the capacity of the counties to begin to do tracing and bring back the mothers and ensure that all the clients are brought into care and followed up. So actually this has been followed up, but partly due to the stock-taking meeting that we actually had. So I think that's all we could add. Thank you very much.
Thank you to both teams for sticking with us and answering all of the questions. I think it's been an engaging and lively webinar and Q&A session, and we will be sure to follow up with the presenters if there were any questions that were unanswered and include them in the summary that we will send out. So next up is Nande, who will wrap up the webinar and discuss next steps on behalf of the co-chairs of the IATT Monitoring and Evaluation Working Group. Bear with us as we load the presentation. It will be very brief as we close the webinar.
Not yet, no. I present now. Okay. Thanks, Jessica. So in the interest of time, I'll go very quickly into outlining some key activities that we plan in follow-up to the launch of this B plus M&E framework. In October of 2015, we plan a multi-country dissemination for 13 countries coming from East, Southern, West, and Central Africa. This meeting plans to go with significant detail into the aspects of cohort and retention monitoring, enhanced monitoring, and also cover aspects of subnational analysis, as well as the use of dashboards and cascade analysis to enhance data use. Subsequent to this, we hope that there'll be huge momentum within the regions and countries, and that disseminations can take place at regional level, whether it's East and Southern Africa as well as West and Central Africa, and that we can also have country dissemination so that we ensure that this information is cascaded downwards. We hope that there will be implementation activities taking place that are focused on the 4 recommendations that Jamie outlined during his presentation in summary of the B+ framework, and also take into account some of the lessons learned that we've shared today, and that will also come as outputs from the meeting that we plan to have in October. Just to shed some light on some of the key outputs that we're hoping for, we hope that through this process outlined, we can have case studies, documented best practices, as well as a tools repository, so that we create a vibrant learning space and reduce as much as possible the learning curve that countries have to go through as they begin to review, adapt, and update their monitoring systems. We hope that as a result of this adaptation and adoption of these practices, that there will be improved data quality, that we will observe enhanced data use for decision making, and ultimately that we'll be able to use program data for outcomes and impact assessment. So with that, I'll hand back to Jessica very quickly to round off and give our thanks and farewell.
Thank you, Nande, for wrapping up the webinar and summarizing the next steps, as I'm sure countries and our participants are very excited to contribute to these efforts and to are eager to reduce the learning curve, as you've said. We'd just like to commend the country teams in Uganda and Kenya, Brian Pazvaka-Vambwa of WHO, as well as all of his colleagues in Kenya, Dr. Rose, who could not be with us today, the CDC team, and as well as all other partners in Kenya who contributed to the very engaging and illustrative presentation, as well as our team in Uganda, Dr. Linda Nabitaka of the Ministry of Health, Dr. Moses Walakira of EGPATH, our UNICEF colleagues in both countries who also supported the presentations, to James Houston of CDC, who gave our initial overview presentation. It's really been a collaborative effort in putting together this webinar, and thank you to all of the participants for joining and for asking really insightful questions. And we will distribute all of the presentations, the recording, the summary by the end of this week for your information, as well as try to collect all of the resources that were mentioned here so that countries can read through them and also adapt them as they see fit to their contexts. We will be having a webinar next month, and we'll send an announcement about that webinar shortly, so we hope you all can join us. Enjoy your day, and we look forward to hearing from you soon.
Thanks.
Thank you.
Thank you very much, Jessica.
Thank you,
very
everyone.
much. Bye.